Hi guys, hope you're well. Welcome to day 14 of the Aurora AKT 30-day challenge. We're almost half there. Hope you've enjoyed the first 13 videos, the first 13 questions. Welcome if this is the very first one that you're watching. Welcome back if it's one that you've been following since day one. We're going to go into another question very quickly. It's a clinical question again today. Once again, if you know anybody else who you think may find these challenge questions useful, please do tag them, comment on them, share this to them, and let them find them, because hopefully we can help as many of you as possible in that final really important push towards the AKT exam. So as per usual, 57 seconds to answer the next question coming up. Have a think about it, jot down the answer, think about the answer that you think you would put in the exam situation, and then we'll come back on the other side, do some teaching about the topic, but also some technique stuff that may have helped you answer this question, even if you don't quite know the knowledge to the level that you would want. So without further ado, let's go on to the question. 57 seconds starts now. That's time, guys. 57 seconds. So well done if you got the answer as D. D is the correct answer to this question, and we'll go through the guidance in terms of both H. pylori management, but also dyspepsia management as well, because it's a very common thing that comes up in primary care exams like AKT, because it's bread and butter for general practice, something that is seen on a day-to-day basis in GP land. Say you see a 34-year-old male patient whose H. pylori test has come back as positive. Which of the below medications would not feature in eradication therapy options as per NICE CKS? So again, the first thing to make sure is you not miss the word not. I know a lot of you guys watching this would have probably just skimmed past that, which one of these medications would feature in eradication therapy, and you'd look straight for the one that pings in your mind, and you'd put that as the answer. So again, we look at the big words first. So you might spot medications, H. pylori, eradication therapy, and those are the kind of buzzwords that stand out. And you miss the small words like not, which make a huge difference. So then that's the first piece of technique to look at. The second bit of technique is to make sure you're not drawn in by, again, buzzwords in the answer. So for example, you may read lansoprazole 30 milligrams and already clock on as if that's a true one. So you may know we're looking for the false one, or the one that's not correct, but your brain will think lansoprazole 30 milligrams. Yeah, I'm sure lansoprazole 30 milligrams is something I've read, and you almost miss the OD parts. Of course, the reason that this is not part of the guidelines is because it's a once a day, whereas all PPIs, if you're going to use them as per H. pylori eradication therapy, then it's going to be a BD approach. So maybe you might have looked at esomeprazole and thought, okay, this doesn't quite ring a bell. Like I've not quite read about that in H. pylori, and therefore you might have put A, even though that's a correct answer, because there are a number of different PPIs that can be used as per CKS for the PPI option. The other bit of these are the 3 antibiotics, and again, you kind of have to know the guidance to a certain level. It's not just maybe enough to know a single option like PPI plus Amox plus Clarithro. The guidance suggests that it's PPI, I'll go on through this in a second, PPI plus Amox plus either Clarithro or metronidazole. So both of these can feature in eradication therapy as per NICE CKS. But you may have looked at that and thought, well, it has to be an antibiotic because there's 3 of them. But actually all 3 of these, and the doses are right. So when it comes to AKT, it's not just enough to know names of drugs. You've got to know dosing, particularly for things that are as common as H. pylori eradication therapy in terms of being done in primary care. So D is the option here. And we'll go through this in a second, but watch out for your brain picking up on big value things like lansoprazole 30 and missing out the OD. Make sure you're not missing out things like NOT as well. And sometimes your gut feeling might think, oh, I haven't quite read that, but actually you've got to think twice as to could that be an option, even though my first thought might be to disregard it. So let's go through a bit of dyspepsia then. So, well, what is dyspepsia? These different things, different people, but pain, reflux, vomiting, indigestion, heartburn for 4 weeks. That's key. So if you had a question about dyspepsia and you're looking at ongoing management, think about, has it been there for just a week or longer than that? For example, 4 weeks is the key. Lots of different types of dyspepsia, of course. So knowing what these are and knowing the differences in management of all of these is important. So uninvestigated dyspepsia is the one that you may see very commonly in question. So this is somebody who essentially hasn't had an OGD, so you haven't had a look down there to see what the potential cause is. If you see a question on functional dyspepsia, this means someone's had an OGD, the OGD's come back normal, so the endoscopy is normal. That's termed functional dyspepsia. Of course, you could have gastroesophageal reflux disease. That might be a diagnosed condition that somebody has. Peptic ulcer disease, of course, so gastric ulcers, duodenal ulcers. And again, remember that just a side track, there are differences in management or post-treatment management if someone has got a DU versus a GU in terms of rescoping. So we covered that in our online courses. Barrett's esophagus, so that's important to remember if it comes up in a question in terms of recognizing it first and the risks of going on to cancer. Second, then of course, dyspepsia could present with as upper GI cancer. Look at medications because, again, you look at a question and you see this is dyspepsia and you look at most common causes, and you might think about lots of things, lifestyle changes and things that are not great from things like stress and alcohol and smoking and those kind of things. But actually, you may miss in the question that someone's taken an alpha blocker, for example, and they've recently started it, or and that's probably the commonest reason. So you look at the answer in GP land, which is the commonest cause. Is more important than sometimes the very first buzz thought that comes to your mind. And we all think about, of course, NSAIDs and steroids, and don't forget SSRIs. So again, on a side point, say someone's in the question, it says someone who has osteoporosis. As a side thought, you should be thinking they're on bisphosphonates. So if it's a dyspepsia question, that needs to be thought about. Someone's got a history of depression. It may not say they're on an SSRI, but the fact they have depression and the fact they've got dyspepsia, you've got to think about they could be on an SSRI. For example, calcium channel blockers, alpha blockers, there's lots of classic causes of dyspepsia, but they may not be so obvious in terms of listed in a question. Any red flags, of course, make sure you know your upper GI referral guidelines. 4 things that you can choose from: direct, urgent endoscopy, urgent ultrasound scan, urgent gastro consultant referral, urgent CT. I think we did a video on this earlier on, if not in the questions, and certainly on our YouTube channel we have one. So make sure you don't miss those in a question because they of course will change the answer significantly. And then know about the management of uninvestigated dyspepsia. So there's 2 main strategies to think about. First, do you go with a full dose PPI for a month and review, or do you test plus or minus treat for H. pylori? So how do you do a H. pylori test? 2 methods are suggested, but an ICKS, a urea breath test, or a stool antigen. So you choose one of these 2 strategies first. Hopefully it'll settle down the symptoms. If symptoms persist, then you flip, isn't it? You try the opposite one to whatever you tried first. So look out for questions. For example, someone who's got dyspepsia, they've had 6 weeks of full dose PPI. What do you do next? You do this. If it says someone's got dyspepsia, you've tested and treated for H. pylori, what do you do next? You flip and you do the PPI for a month. So it's about knowing what the guidelines say, what the question's saying, and not missing little things that can change the answer significantly. So what about the eradication therapy then? So 7-day triple therapy, of course, so a week triple therapy. 3 things: PPI, BD, and there's a whole host of PPIs that you could probably use: omeprazole, lansoprazole, esomeprazole, pantoprazole. There's quite a few to think about. So have a look at the guidelines to make sure you see which ones are there. But it's a BD, that's the key, full dose BD. Amoxicillin 1 gram BD, slightly unusual dose, isn't it? When you think about amoxicillin, you think 500 TDS. It's kind of the buzzword that comes to your mind. But Amox 1 gram BD here. And then either, like we said, either clarithromycin 500 BD or metronidazole 400 BD. So that's why all 3 of those antibiotics in the question were all okay. And then second line, if someone has first line therapy, not better, still has H. pylori, then you can think about second line options. And it depends a little bit on what they've had first line, things like allergies and interactions. But things like levofloxacin, things like tetracycline, things like tripotassium may come into play. But I guess in primary care exams, you're probably going to get more asked about first line therapy because that's obviously what people do or have much more commonly. And then, of course, there are indications for gastroenterology referrals. So you've got your 2-week referrals to rule out cancer, and then you've got your non-2-week referrals. So you've got your whether you refer for gastroenterology referral or an OGD, if someone has recurrent symptoms or refractory symptoms despite primary care treatment. So look out in a question, for example, they're telling you all this stuff that somebody's had, they've still got symptoms. Yes, look at medications and do all those things that you need to think about doing. But then is this person in the category for referral? Referral for dyspepsia may not be something that's done very commonly because it's managed very well in primary care, but you don't want to miss the indication for someone to be referred in an AKT question. So hopefully this makes sense. That's why D is the answer here. Congratulations if you got that right. If you didn't, hopefully you learned something from this video. If you want some more teaching in the build up to your exam, a couple of weeks to go now, just over a couple of weeks, you can still make full value of these audiobook courses. If you're getting a bit stressed now and you're thinking, look, I've not got enough time to cover everything, then use the audiobooks. They're designed to buy you time. You buy them, you download them straight onto an app on your phone, and you just listen to them. Some people I know put them on before they go to sleep. They just kind of let it all sink in. Certainly people listen to them when they're commuting, out exercising, jogging, whatever it might be, but they will buy you time. And sometimes, you just need to hear something 2 or 3 times for it to make sense. Therefore, the more you listen to these audios, the more they'll seep in. And every time you listen to it, hopefully you'll pick up something new. So there's 3 different audiobooks, depending on which particular area you think you might be weak in at this point: clinical, stats, and admin. Like as I always say, unlimited use. Listen to them again and again and again, and make full value of them. You can get a triple bundle just as a discount, but remember, whatever you do, make sure you use this code Arora Video 10 to get the extra 10% discount for having watched this video. Hopefully this helps. Hopefully, I know a lot of you guys are using these audiobooks already, and I know they're of value to you because I know I'm getting some really good feedback, so thank you for that. But if you haven't, then have a listen to some samples on the website and see if you think you could learn by audio, and if so, then make full advantage. Hopefully this has been of some value to you guys. See you tomorrow for day 15. Have a good rest of the day.